Good evening, everyone. Welcome you all on another exciting webinar on swallowing. Today, as we celebrate World Swallow Day, we have two eminent speakers with us to talk about swallowing. As a private practitioner, we always have doubts when we work with swallow, how to go with it. So this group, the motto of SIG SLP private practice is to help private practitioners to work better in their profession. So for this, we have taken this topic today. The theme for today's Swallow Awareness Day is Dysphagia, a difficult diagnosis to swallow. So not to take more time, I'll just like to introduce our first speaker, Mr. Prasanna Hegde, Program Director, uh, Speech and Language Pathology, Consultant Speech and Swallow Specialist, Department of Head and Neck Surgery, Oncology, SCG Hospital, Bangalore. We welcome you, sir. Stage is yours. Thank you.
Yeah, thank you, Garima madam. And thanks to ISHA and SIG and Chandan and team for inviting me to be the part of this program. And I'm happy that I have one of my friend with me who's Bhaskar, who's also specialist in neuro swallowing disorders. So just want a quick check. Is my voice audible and is my screen visible?
Yes, yes, it is.
Yes, all good.
Yes.
Okay, so yeah. So my topic is setting up swallowing clinic. It is mostly an idea. I mean, I'm not going to give you detailed description about how you start a swallowing clinic. I want you to think about yourself, why you would want to, or who can do it, or how you would play a role in somebody's swallowing clinic, or if it is a hospital, how you should establish yourself. So the topic is swallowing clinic in mind. Do not fear, listen here. It is just a funny statement which I wanted to make. So I work at HCG Hospital. I have been lucky to have Dr. Vishal Rao, who's an advocate for me and my services, and then we are able to expand to things which are ignored in head and neck oncology and rehabilitation. So, and I also have a very good rehabilitation team which supports me for all my adventures and outcomes. All right. So why there is a need, all right, and why one should have need to establish a swallow clinic. Now there are different things. Now I'm going to talk candidly about these things, and some things may be funny, some things may be relevant to your experience, or some things you might have seen others facing, right? So why I would need to establish my own clinic is that I would like to have an independent clinical practice, not dependent on anyone else. Knowing that people would come looking for me. So this would happen at a later stage in your clinical practice or professional career. And there is a scope in a geographical area also. Now you find that a lot of patients are coming to Bangalore or any other city on a particular day. There is bulk booking from some areas, and I would like to give an example. When I was working in Nimans, we used to get maximum patients in OPD from West Bengal on Thursdays. So we found out that there was a train coming from Kolkata. I'm sure Bhaskar will agree with that. That's called as Howrah Express. Whenever Howrah Express came, there are three or four hospitals in Bangalore which will be filled with patients from West Bengal. So these are the things which you would take a consideration about how and where you are going to have more patients, what kind of patients are coming to one area. And it also depends on whether there is medical tourism active in that city or which area it is. Is there any congregation of hospitals in that city? All right. So there are other things like you can't work under someone. It could be personality trait. It is okay to be wanting to work alone. Provided you take a lot of risk in advertising yourself, getting that skill which is required without another team member, or at least have partnership with someone where they don't interfere in your clinical practice. And some people also say that no, they have to follow trend. Everybody is having their swallow clinic. I know I might also have it. And some people say that, oh, let's just have it. I can do it, so I'll let me have it. Whether patient comes or not, it doesn't matter. I just want to have it for my name. And also there are other reasons, like I can invest in instruments where where I can have a clinical setup with gold standard instrumentation. You may not be able to have a video fluoroscopy. It is too expensive when compared to endoscopy. But if you can afford that kind of money, I think you should be doing it. I want to give an example how one person should be smart enough to channel their money in the right direction. When I was setting up my clinical practice, and then I opened up a private practice. We had around 12 places of consultation in Bangalore, and at one point we had 8 to 10 speech pathologists working with us. So all my investment, all my salary, all my father's money went into giving salaries to professionals. So there are 10 people, so you would say 10 into 25,000 per month. So my expenditure would have been much higher. All right. So instead of that, if I had bought a fiber optic endoscopic evaluation station or endoscopy station, I would be at a much better position today when compared to just investing on other speech pathologists. So you need to understand, what do you invest in? Do you invest in a sofa set, or you invest in lightings, or you invest in wallpapers, or you invest in a area? Okay, what do you compromise with those things? So just by having money, you cannot get everything. You need to channelize as well. And last reason is, you would want to experiment and see if it is your cup of tea. You want to take an adventure, whether you'll be able to survive or not. So that is also possible. There are different people with different mindset. So based on that, your need will be different. All right. So who should start it? Not necessarily a swallowing specialist should start it. Anybody with money can start, provided they recruit people who are with right skills and with right professional mindset. So if I have to go through this slide, this each thing has its own message. Those with the following should consider starting their own swallow clinic. The person who has money, they may not be a speech and swallow specialist. And second one is a person who knows where is the source of money. That can be a bank, that can be a venture capitalist or venture investor, or somebody who knows about their father's or mother's savings, or bank balance. So in those cases also, you'll be able to figure out whether you'll be able to convince your father and get the money source to start a clinic. And even if you have an access to infrastructure, you don't have to spend a lot of money in terms of having a clinic or anything. So you just have to start a virtual kind of clinic, or you can have a partnership with the person who's running that infrastructure, and then have revenue sharing model, all those things, right? And then if you have a good referral source, you should be able to start safely swallowing clinic with minimal investment, and then going forward you can upgrade the infrastructure and instrumentation in your clinic. If you have education, of course you can start, but you need to have skills also. There are around 1200 registered speech language pathologists registered in ISHA. So I don't think more than 20% are working in the areas of swallowing disorders. So skills also matters. It also depends on your interest, and you need to have a good team in place. If it is a hospital, then you need a physiotherapist. If you need an oncologist who would be referring patients, radiation oncologist or surgical oncologist. Even a dietitian would come in handy when you're deciding alternate feeds. And the last one is, you need to have strong why. If you don't have a direction for your career, the one which you discussed before, your direction in your career could be either making money, making name, or helping patients. All these three things works. Ultimately, it is the patient who is going to get benefited. So making money, you make money in the right way. So those things you need to look at. All right. So where do you do it? So we answered why we have to do it and who has to do it. Where do you set up your own clinic? You can have in a OP setting, outpatient settings where patients are coming in the morning and going in the evening, or you can have in a IP settings where patients are getting admitted for other procedures and parallelly they get treated for existing swallowing problems or swallowing problems which may arise because of the treatment. This IP settings can be single specialty or multi-specialty centers. Multi-specialty is more revenue yielding when compared to single specialty centers, but there are uh, you know uh, places where single specialty also does a very good job, like in HCG is a single specialty center and we are having full caseload. Like for example, Tata is a high volume center. Tata Memorial Hospital in Mumbai, it's a single specialty center, yet my friend Arun Balaji is always busy, and there is another colleague, two people are busy together. So that means there is more work in a single specialty centers as well. So third one is you can sit in another person's or another professional's clinic and make your make your participation in clinical decisions, and you can practice your profession. And you can also have your own clinic. That's also comes with do's and don'ts, what you should be doing and what you shouldn't be doing. And you can also have home care facility available for your patients. These things, home care does not require any kind of investment unless you're going to carry a mobile fees unit, that is going to cost somewhere around 10 lakhs. And also you need to have certain precautions taken at home care. And other settings like skilled nursing facility or old age homes also can support your practice based on how much revenue is generated and whether they can afford you or afford your services. So how do we start it? The biggest question is who's going to fund your activity. So you may choose to be a freelancer and keep going to different centers and seeing one or two patients in every center, or you want to have your own physical presence in one of the locality in the city. All right. So in those cases, you have to convince your bank to trust in you. So that means there is a famous saying: loan is given only to a person who can repay it. All right. So there are two kinds of trust. One, a bank will trust somebody with money, and the second one is bank will trust if they see that you are potential to run this show. All right. So there are loans like MSME loans or business loans. We can have there are different interest rates for doctors or clinicians. You can approach bank for that based on why you need it. You want to have an infrastructure, that is own house or convert into a commercial space or rent it, or have a small setup in somebody else's clinic. That also is possible. And second one is you break your savings or you break your parents' savings. Both are possible provided you are able to achieve your monetary goals. That is, you have to repay your own bank balance as well as your family's needs. All right. And the last one is venture capitalism. That is, a person is going to put money in your business or in your service thinking that that will yield 5 times or 10 times profits. And if there is loss, it is a loss of money for the venture capitalist, not you. So the person who's putting money is going to take risk in your business. So for that, you need to pitch your idea to a person who's ready to spend and then take it forward. It's a difficult thing unless they see a scalability and more potential in the market. If it is a product, yes, they will do it. If it is a process or a service, they usually do not do it. You can, keep trying about getting those kind of funds. You can be creative as well, like I told the mobile health clinic. If you have a vintage car of your father which has not been used, you can convert that into a vintage car. You can just use it for logistics purpose, or you can have a mobile clinic like in the picture. Right, mobile clinic is where the patient comes into the vehicle, and if it is just used for logistic, you can carry all the materials required wherever you're going. So that is going to add face value to you, and people are going to accept you as a professional. All right. So there are other things like you can take risk. Because of COVID, a lot of people are taking home tele rehabilitation for swallowing, disorders, and there are cautions put forth and guidelines for swallowing rehabilitation using telemode. If you are kind of the person who can take risk, I think you should go ahead and do it. Only thing is you should make your monitoring skills better with these kind of settings. You should have a good internet connection. Your customers should have a good internet connection, and also you should have legal policy in place. You should have informed consent. You should get a informed consent from the patient signed that he is agreeing to all the risks that may happen during the course of treatment. So to begin with, you need to identify a geographical location where all those, what I discussed before, where is the referral source, whether it is accessible in the city, and all those things you need to be seeing. The place should be accessible in the city. It should be closer to the referral source. It should be closer to the emergency response center. It could be the emergency response center can be a small hospital with an emergency room or emergency setup, or any hospitals which has agreed to respond to your emergency calls. All right, and also it should be there in a non-commercial area where patient might have hesitation to come to a commercial area where a lot of crowd is there. All right, and it should not be a secluded place as well where there are no road facility, nothing. These are the small things which will make your business success. So every service needs to be treated like a business. If you don't treat it like a business, it will not be successful. Even if you do charity, somebody has to pay for the service. All right, if not patient, at least organization pays for it, or you raise the fund for it. Nothing comes for free. All right, so the place should have ambient environment. It should not be intimidating to the patient. I put this photo just to make sure that I tease Bhaskar. Bhaskar may be comfortable in this area because he's a Bengali. Bengalis are known for their love for fish. It's just for jokes. I think Bhaskar doesn't mind this. So once you identify a place, you need to have, you also have planned your source of fund, and you need to look at what are the capital expenditure you're going to incur. You need to have minimum of 10 by 10 feet room, which is important for, setting up a clinic. Even the government regulation mandates to have 10 by 10 rooms. At least one room should be okay. But if you want to give luxury or a good experience to the patient, you need to have additional rooms, waiting areas, reception, toilets, storeroom, procedure rooms. All those things are, kind of required because you never know when the nature calls, right? So even every public places will have a toilet, so there should not be any problem for you to have a toilet. You might need it to use it for your purpose as well. So you need to look at furnitures, you need to look at lighting and ventilation, utensils to be used for your procedures, desktop and laptop for documentation purposes, digital as well as hard copy should be done, and there should be enough storage space to record all the videos, especially if you're doing fees or barium swallow in your clinic. Barium swallow may not be the case, but fees, yes. But if you are doing a video recording or audio recording, you should be doing it. All the hard copy documents should be converted into a digital copy. You never know what might happen. If at all there is any legal proceedings against you by a patient, you should require those documentation. And laptops are also important for you to conduct those studies. You need to have monitor, you need to have softwares installed on this in the laptop for your procedures as well. So there are some of the specific investment for instrumental evaluation. You can have a digital cervical auscultation system. It usually comes with a digital swallow station, or you can have your own stethoscope, good quality stethoscope integrated with a very good quality mic system. You can have an endoscopy or laryngoscopy suite. It can have a rigid endoscope, flexible endoscope. It should have a light source. It can come with a stroboscopy unit as well if you are having a voice clinic with a swallowing clinic. It should have a recording system. It should have audio and video recording system. It should be able to take photographs. And if it is stroboscopy, it should be having 50 frames per second or 50 pulse per second. If it is regular video, you should have at least 24 to 30 frames per second settings. All right, and seating also is important. You will not be able to do fees evaluation or any kind of evaluation when the patient is standing. If you don't have adequate seating arrangements for the patients, you may not be comforting the patient for coming back again. Returning customers are important, and they're going to do marketing for you. They're going to talk to different people. They're going to go and talk to their medical consultants. All right, so that's how you build your caseload. All right. Fluoroscopy, I put it in red. I am not sure which private clinic has a fluoroscopy, but in a hospital setup, which you're going to talk about in a while, and in a small setup, you should be able to have a sterilization equipment. If at all you use any kind of instrument, you should be sterilizing those things as well. All right. So there are consumables. Of course, these are silly things, but we usually ignore it. If somebody is interns with your place, and you ask the interns or fellows to prepare for a fees evaluation, you will know what are the things they would forget. As simple as water, people would forget. As simple as glass or a disposable cup or syringe, they would forget. So you should have everything ready. Once anybody who is passing the scope is finished passing the scope, the patient will not be comfortable for longer duration of time. You should be ready with it and make sure that you complete the study as early as possible. All right, for that you should have everything ready. You cannot run to a shop to buy a disposable glass when you already passed the scope. All right, you need to have dyes and food colors to do any kind of dye testing or leak testing, or even called as trichostomy. That's a modified Evans blue dye test for trichostomy evaluation. You need to have contrast for barium swallow evaluation. You need to have stationaries. You need to have edibles for food trials. You need to have personal protective equipments. If you are doing fees where it is more of an aerosol producing procedure, you need to be careful about your health as well as your family's health. And also there should be chemicals or materials for sterilization of the room, the furnitures, the instrument used, as well as the devices. Right, these are consumables because you need to keep refilling it, or some things usually will come with use should be stipulated to only this much time. After that, validity goes off. Right. So human resources, if you have a clinic, you need to pay yourself if it's not for profit. If you're doing charity, you don't have to worry about it. You need to make sure that you are making enough profit, at least to meet your expenses. Colleagues may be there. You may share the revenue with them, or you may have consultation charges. It is ideal to have an ENT with you if you have a scope or a endoscopic unit. You might have an assistant or OP nurse. Usually it's a luxury to have OP nurse with you if there are no ENTs. In case of fiber optic endoscopic evaluation settings is there. Receptionist may be there, may not be there. It depends on how well the clinical establishment you are done. Helper, housekeeping, auditor, lawyer, all those things are important. So this all depends on what kind of company you have opened. Is it a proprietorship or on basis of partnership? Who's the partner? Is it a sleeping partner or is it just the financial partner? Are you going to be just salaried, or are you working with somebody else or in someone else's clinic on salary, on revenue sharing model, or pay for service model? All these things are important. Based on this, you will be able to dedicate your time and energy. So administration work, all this register needs to be in place, like salary slips, stock registers, client register, query registers. All these things looks very silly, but it is very important. In most clinics, you are the person who's opening the clinic and closing the clinic. In those cases, you shouldn't be having any problem doing so, because you're going to start very modest. You may not have full-fledged clinic. You have to start modest and keep building as and when you become more skilled and more confident on handling risk areas. And clinical skills or clinical documentation, you need to have operating protocols for yourself, structured or standard operating protocols, disease specific protocols, function or dysfunction specific protocols, what to do when a patient comes with such so and so problem, what should be the emergency management protocol, documentation, screening tools, such, if a person is having cognitive deficits, you need to know before you conduct a swallowing evaluation. So you need to have screening tool for that as well. Just because your clinic is swallowing clinic, that doesn't mean that you don't do any cognitive assessment, right? And you should have assessment tools for both clinical examination as well as scales which can be used with instrumental evaluation. And also you need to have infection control protocols. Other documentations like case history, assessment forms, plan and counseling form, informed consent form, which is very important, progress sheet. It depends on whether you're giving patients any document, discharge report, if at all, is there any protocol like that, referral format as well as billing format. Next important step is registering your clinic. First, you start with registering your logo and name. You can have copyright registration. And then you work on infrastructure and make sure that your clinic is registered under Shop and Establishment Act. It is state dependent. After that, you can have Clinical Establishment Act. Not necessary every state will support this. This is a central government act. This is usually hospital as well as, or polyclinic especially. A single specialty clinic might not come under this, but you need to have a Shop and Establishment Act, which is specific to the state government. And you also need to have professional registration under the professional body, that is Rehabilitation Council of India. And if you are having an OT or a PT or any other medical specialty, you need to make sure that they are registered under their specific professional body. Legality, you need to have, at least you need to know a lawyer. You should have a clear protocol about all the documentation which I mentioned before. Informed consent, again, I'm stressing, you need to have informed consent. Also, treatment rejection documents. That means if you suggested something and the patient rejected to undergo that treatment, you need to make sure that the patient signs a document, logbooks, knowledge about consumer protections, medical legal knowledge, know the old horses. That means you need to know your seniors who are already practicing in this area. They would be able to help, whenever you are in problem. You need to make sure that you have a good rapport with your association like ISHA. ISHA will be able to help you with these kind of cases. Now, associations only to help the professionals, right? And study cases and verdicts in the past. India, there's not much. You can study all the US or UK cases. Indemnity bond if you work in hospital, and insurances need to be taken care so that you are legally safe. So this is a book with case studies in dysphagia malpractice litigation. You can study this. I'm not sure if it is valid for India, but we are not far too long, from getting a case which can be against any one of us. All right, because more and more awareness has been happening in general public. You need to market yourself. That's very important. All the registration processes in one hand. If you don't market, whatever you do, whatever investment you do, you'll not be able to do anything with the skills you have. All right, newspapers, pamphlets, flyers. Google should know who you are, or at least what is your clinic and what services needs to be, or what services is given, should be present in Google. All right, if Google doesn't know, that means you are not visible for the crowd. Why I put Ola is because not necessary everybody will come from your locality. You need to have a set of professionals working in different areas, so that when a person comes from far off places, you need to be able to refer to those specialists in that area. So Ola is taxi aggregator. Just like that, you need to have aggregation of all the specialists who are working in the city. All right, and you should make sure that you are enlisted in Just Dial, track to at least the free registrations or free listing. Okay, if you're employed in a hospital or in any other setups, like how I said, the government setup, moderate to high volume centers like neurology centers or pediatrics, head and neck oncology, or multi-specialty, or even just a low volume center where they can afford your services. Like in government setup, not necessary there will be high volume, right? They would be trying different kind of setups. You may not have that kind of work. So once you get recruitment in these setups, so you need to make sure that you assess and understand everything possible in that area. So you need to have your roles and responsibilities clear. Why I want to express this is because not necessary that everybody would want to set up their own clinic. Best thing to set up a clinic inside a clinic, right? So because you are safe, you have some kind of safety from medical fraternity. Also, you need not when spend a lot of money. You just have to make sure that others believe in you. All right. You need to know what is your scope of practice. You need to know what is the other scope of practice. You need to know what is the weakness or ignored aspect. For example, usually uh, tracheostomy care is done by medical specialists, that is ENTs or head and neck oncologists, head and neck surgical oncologists, or nurses. If somebody is not doing, in some places, physiotherapists also handle these things. If somebody is not doing and you think that no care is not happening, there are a lot of patients coming with emergency, then you have an opportunity to pitch in your things. And that's what I did in HCG, and we are able to manage all the patients with tracheostomy. As soon as the tracheostomy happens, a sister calls me for a consultation. So that is the kind of awareness you need, or sensitization you need to do it in the hospital. So you need to understand protocols of individual departments, infrastructure, what is available and what is not accessible. It may be available but may not be accessible. For example, a C arm in an OT is not accessible for a fluoroscopy, right? You'll not be able to do a fluoroscopy examination in an OT. So you need to understand those things. You need to also understand who is accessible for you, which areas are inaccessible, and who is your advocate, biggest advocate. For me, a head and neck surgeon is an advocate. For somebody else, there may be a radiation oncologist who would be sending more cases. All right. And you also need to identify opportunities as well as challenges. Challenges here means you would know somebody may not like your face, or may not believe in your services, or may have different reasons for it. You may not have got back to that consultant after their referral. They would want to know what happened to the patient. So you need to make sure that you go back to them and discuss all the cases that are referred to you once you finish their care. So why would someone invest in you? If somebody invests in you, is because of your value. That value comes from your direct revenue, from your consultation and from your procedures. Indirect revenue, because somebody would take a surgical treatment in a hospital, for example HCG, because there is a rehabilitation specialist or a speech and swallow specialist. That becomes an indirect revenue. And then that patient goes and tells other patients that no, you go to this hospital. That's because there is a good team of specialists who will be taking care of the patients holistically. So that becomes an indirect revenue. Value addition, because you are going to improve the quality of service of other specialties as well as quality of life of a individual patient. So with this, I would like to conclude my presentation, and thank you for giving me opportunity. I think I took 6 more minutes from the stipulated time, and Chandan has just messaged me that it is 5 minutes past 8. So thank you, Chandan, for allowing me to continue for 5 more minutes. Thanks.
Thank you so much. It was actually very nice to know that you have mentioned so much in detail about how to set up a protocol. There are a few questions which we would like to take it in the last.
Yeah.
Thank you so much for the presentation. Next, I would like to invite our second speaker of the day, Mr. Bhaskar Day. He's going to present Safe and Efficient Swallow Meeting the Expectations. He's a speech swallow pathologist in AMRI Group of Hospitals, Kolkata. I welcome you, sir.
Yeah. Am I visible? Hello. Yes.
Yes, you're
Uh,
audible. You're visible.
yeah. Thank you. First of all, happy International Dysphagia Day to all. Like, we are dysphagia specialists and speech language pathologists, so we should be working on this area to solve the problem of patients having swallowing problem. So we'll celebrate this day. And thank you, Isha. I thank Isha for giving me an opportunity to present whatever practices we are doing these days and to shed some light uh, on the topic. And that was an excellent presentation, Prasannaji. As always, you have fired up the stadium. And let's go with my presentation now. Let's try to keep the expectations high. Is my screen visible?
It's visible.
Hello.
Yes, yes. Yeah.
Yes,
Now
Bhaskar, yes.
Okay, thank you. So we'll start off with the topic safe and efficient swallow, meeting the expectations. This would I would start it off with a few simple definitions, if possible. Okay, so if I'm talking about deglutition, uh, yeah, deglutition. We all know that deglutition involves a complex series of voluntary and involuntary neuromuscular contractions proceeding from mouth to stomach. But the importance of this is the topic is safety, which refers to the ability to transfer the bolus from the mouth to the stomach without penetration or aspiration into the lower airways. This is the safety part, and the efficacy part is it refers to the ability to transfer the food bolus from the mouth to the stomach without any post-swallow oral or pharyngeal residue. So the efficacy and the safety are different terms. Like for safety, the life may be at risk. For efficacy, the quality of life, nutrition, these are at risk. Okay, we'll come in details in the later slides. Okay. So this is a simple process of deglutition. As you all can see, a person is trying to drink water. The water is going inside his mouth. The back of the tongue is raised. Now slowly the water passes into the esophagus through the pharynx, and then the person swallows. That is normal swallow. In aspiration, you find a bit of water trickling inside the trachea, which on longer cases may cause aspiration pneumonia, and the patient might have problem. As mentioned before, I work with mostly neurological disorders because of my advocate, who is a great neurologist. So these are the most populations we find in the clinics on a daily basis. And if you can see what I've marked, what I've tried to show in brackets are the number of patients who has dysphagia and like the end of life issue for these patients. If you can see, for example, a Parkinson's disease might have 50% of a Parkinson population have dysphagias. We always encounter a PSP variant of Parkinson may have 83%, whereas ALS, amyotrophic lateral sclerosis, always have 100% dysphagia. That is the main reason for their death. So we as speech language pathologists should be able to solve their needs and to improve the quality of life. Okay, so few basics I'm going to talk about. Where to look. Impairment can occur in one, some, or all the four phases of swallowing. What we should look for is aspiration or malnutrition. Who will look after this? Either neurologist or speech language pathologist or laryngologist. The gastroenterologists mainly look into the esophageal dysphagia part. And how to deal with it? We have got external feeding tubes, diet modification, positioning, and therapeutic intervention. Okay. Now, I'm going to talk about a bit of aspiration, as this is one of the most important terms what we come across when we deal with dysphagia. The pre-deglutitive aspiration are aspirations when we see that the patient is chewing the food, and prior to swallow, the patient starts coughing. Interdeglutitive aspiration is the most common, which happens during the swallow, and sometimes it is post-deglutitive aspiration. If you remember the definition of efficacy, here the efficacy has a problem. The patient is not able to remove all the residue, food residue. So there might be a chunk of food residue which might penetrate inside the laryngeal vestibule after the apnea is over. Okay. Okay. Now, what are the aims of swallow intervention? What we look into? What is the broader picture? We should look into the meeting the patient's expectations. What is the patient expecting out of it? Creating realistic expectations, and also we should make a balance between the quality of life and the life expectancy. Okay. Okay. Now, what meeting the patient's thoughts or expectations? This is very important. What does the patient think? Will I recover? How long it will take? What extent will I be normal? Will I be able to afford the treatment? What is my new normal? And will I have to choose between quality of life or life expectancy? So, as an SLP who is primarily going to see or to help the patient with the swallowing problem, I think this points, understanding and counseling the patient with these points are very important. Will I recover? You should always tell the patient, counsel the patient according to the diagnosis. As I deal with neurological disorders, there are mostly two types of neurological disorders. One is progressive and one is improvement after a stroke, what we find mostly. So we counsel them according to that. If it is progressive, we have to give them realistic expectations. How if you do not recover also, then also we'll be able to provide you with a great quality of life at least. Okay, how long it will take to recover, how long it will take, it also again depends on the type of problem the patient is having. We also have to see if the patient is compliant enough to therapy, how well he is expecting to or how well is he taking the therapy sessions, how frequently we can give them therapy sessions. There is a scarcity from the economical part of the patient and as well as the number of professionals present in a city or in a town who would be able to cover up a lot of patients, because you know our professionals are always in scarcity. To what extent I'll be normal depends on different scales what we have got. Like I mostly use dysphagia handicap inventory. That's a lovely scale. It gives you an idea. The patient can evaluate before and after the therapy, and they can have a numerical value out of it, so they can understand where they're standing. Will I be able to afford the treatment? I don't know how much everyone charges for the treatment, but there should be a standardization. Let's see. Let us have an extensive meeting on that. I always thought that all the rates of a swallow therapist who is over experience or experience with patients for this many years or seeing patients with this degree should have a protocol set for the charges of treatment. And what is my new normal? Certain dietary modifications, if it is a tube feeding, if it is some different way, some postural adjustments, you have to counsel the patients. You have to tell them either you want to eat and leave, or you want to look into all these things. So you have to make the new normal. And will I have to choose between quality of life and life expectancy? This whole ball game, if you ask me personally, I give it to the patient's perspective. I ask them, after making them understand this will be the limitations, these are going to be the considerations. I always tell the patients to choose how like they should make the toss. They should either choose between quality of life and or the increasing the number of years. Okay. Now, how does quality of life and quantity of life are balanced? Now, this is quality of life is like living with a gastrostomy tube or a physical brings a physical and emotional aspect hampering the quality of life. The patient has to go into the market with a Riles tube. The patient has to go to a function in a Riles tube. And you know, as we live in India, there is a saying in Bengali that we have got 13 festivals in 12 months. So there's always some or the other thing which is always happening. So the patient going there with a Riles tube is quite pathetic for the patient. How does the quantity of life gets affected? Avoiding oral intake may lead to malnutrition. The person may have different diseases. The immunity system can be maybe less for the person, and serious aspirations may lead to death in few days. Okay. Okay. So quality of life assessment, as I've told before, we do this. This is dysphagia handicap inventory. This is a robust patient report outcome tool. It has got 25 questionnaires, 3 aspects: physical, functional, emotional. It is a closed set, easy to reply, and never, sometimes, or always. And it's a 7-point rating scale. So pre-therapy and post-therapy, you can always get a overview that yes, this patient is improving, or the patient can assess it by himself or herself. And we are trying to trans-adapt it in other languages so that it becomes more easy to deal with patients in Bengali. Okay, now this is very interesting. I call it the swallow safety measures. It's more of like the road safety measures you have got for the police. So you're like a swallow police. You're like a traffic police. You have got you whenever the food goes into the wrong way, it goes into the no entry region. It goes into the lungs. You're the policeman who can stop it. You can go with a green, yellow, and red signal. How is it? Like when you're giving the green signal, you can see the patient, prescribe a diet, and tell for follow-up when you find the problem is not that much affecting the patient. But needs therapeutic intervention and dietary modification, you need to tell the patient to slow down. You have to have an alert system around you. You have to eat with certain methods so that the food does not go in. You can have dietary modification, different type of more softer or mashable diets can be given to the patient. And the red signal is nil per mouth. As a swallow pathologist, the first thing for you in an Indian context will always be the life expectancy. You can tell the patient you are not allowed to eat orally. Please have a Riles tube. If then the patient says no, I'll not go for that, if it justifies with the physician or the other fellow colleagues, you can talk to your seniors, you can talk to your colleagues who are dealing with speech and swallow problem. If you agree and come to a decision, then only you can go for like not only the quality of life. Yes, few more days are left in your life, you can live even without a tube. Okay. Now, how to return back to safe swallow. The safety, support, adequate nutrition, hydration, these are very important. Okay, and determination of optimum feeding methods, techniques, few techniques to start with. We can always reduce the pulmonary complication. The patients and the caregivers' burden can be decreased to maximize other things in his life other than making swallowing only a bigger issue in his life, and develop treatment plans to improve safety and efficacy of swallow. Okay. Few strategies for maintaining swallow safety. This I tell whatsoever the patient is having a mild dysphagia problem or a major dysphagia problem, we always try to do all these things. Even in OPD settings, IPD settings, we say this to take care of this. But what are the do's? For a patient for a patient or an individual who's coming to a clinic and saying that I'm having certain problem while eating food, you should look into all these things. You should tell them to eat slowly first. Second thing, you can tell them to sit in a good posture while having food. You can tell them to take care of their oral hygiene. You can tell them to brush properly, take good care, because oral pathogens are very dangerous. In an old person, oral pathogen alone can create aspirating an oral pathogen can create a big amount of pneumonia. You can tell the patient to have proper timing for the food. It should take a lot of time to have not a lot, but okay, at least a time. You should not eat in a hurry. And then you should tell the patient to chew the food properly. A lot of us in this busy schedule of this city life, we tend to eat very fast. You can always tell the patient, take your time. You don't have to catch a train. Eat slowly. Many people have problem if they just come and tell you that whenever I swallow, I feel pain in my throat. If you find it's a simple pharyngitis, then also you can tell the patient to have water with a chin down posture. It might be able to close the airway, open the esophagus far more wider, and the swallowing can be done easily. Okay. If you feel that you have got something stuck in your throat, we would always recommend not to eat more in that condition or to have water. You can cough it out, clear your throat, make your voice, assess your own voice, tell the patient, train the patient to assess their own voice if it is clear. Now it is clear, okay, now you can have food slowly. Don't try to drink water whenever you aspirate or penetrate. What are the don'ts? Don't drink water like this. Like, don't put your head up looking at the sky. drinking water. The airway is completely exposed. Come on, the water might fall inside your trachea. Don't talk so much during eating. The food might spill inside your trachea very easily because you're not able to attain apnea. So in some conditions, we definitely do say that don't watch TV because your mind is going to be inside that. If you're seeing something drastic or very emotional, that may cause differences in your swallow mechanism also. So it's better in a patient who is vulnerable to have swallowing this or aspirations during his meal time. We tell them to give attention into their swallowing, but do not go on a level of anticipation that you would cough if you swallow. You also have to take care of that. Let's engage them in something different, not watching TV. Okay, while you're coughing, don't drink water. Clear your throat. I've told before. Don't like if in an old patient you feel drowsy. We can always tell that if you feel drowsy, if you feel feverish, if you cannot sit, if your head is banging so badly, then this is most for the geriatric population, not for everyone. A sick person can always eat, but for geriatric population, we mainly say that okay, if you have a high fever or a UTI, you might not be recommended to have food at that time for a time being. You might aspirate and don't sleep and eat. This is highly notable and highly seen in one of most younger ages people also. If you have a simple LPRD induced dysphagia, that might also cause you to cough very badly if you sleep and eat, because that is a wrong physiology. Okay. Now, taking medications, many of the population, genetic population and swallowing dysfunction population, they feel a lot of problem while taking it. The simple most question I always encounter while counseling a patient, that how will I take these big medicines? So you always go to your pharmacy and ask your doctor to give smaller medicines for those. Or if you have capsules, the capsules can be are coated with lubricant material, so it will be easier for you to swallow. You can break down a tablet, make smaller pieces out of it, and then swallow. What I recommend to most of my patients is you can grind the medicine properly, you can make a powder of it, and have it with a spoon of puree diet or whatever food you're having. So this is how I go about. Okay, now coming to the spatial population who needs basic treatment for dysphagia, we look into two basic principles: restoration of normal functions, which is rehabilitative, and modification of diet consistency and patient behavior and changing postures of patient, that is mainly compensatory. Okay, coming to the rehabilitative strategies, we have always told that, and I have discussed it earlier in other presentations also, that it is mostly related to the strengthening of the muscles or strengthening particular movements of swallowing. It's a multi-directional command following, so it might not be appropriate for patients having cognitive impairment, like if you find an advanced FTD or advanced PD even, it might be difficult for them to follow all the exercises. But you can always do it passively if they are not doing it actively. Let's say a forceful swallow, you ask the patient to swallow holding their breath, swallow very hard. So if you have any oral residue left in the mouth, or the pharyngeal residues can be cleared very nicely. Then you have Mendelssohn's maneuver. You try to ask the patient to to push the hyolaryngeal cartilage up and then say E for a long time. You can do that. It helps in hyolaryngeal excursion. And then you have the supraglottic swallow and supraglottic swallow. These are mostly for to increase the efficacy of swallow, to protect the airway. You tell the patient to take a deep breath, hold the breath, swallow, and do a small cough or take it out with a cough. Supraglottic swallow, you can always push and pull your arms, which will give you extra laryngeal support. So in this way, what you're doing, you're protecting the airway. So increasing the efficacy of swallow, you're removing any residues and not supportive of post-declusive cough. In many patients, what I will tell you my experience, in many patients we have seen that the patient has been fed, then after like if you do not tell the patient that you do not sleep just after you have food, then also after 15-20 minutes when they're in a supine position, they start coughing, or it might happen because of two things. They might have a reflux of the food which is already gone inside, or there may be some pocketing of food materials which are already in the oral cavity which may go inside. So rehabilitative strategies without food, if you do it for the patient, this work remarkably good. I find it very supporting. Hope it will be supporting for you also. Then what you have got is oromotor therapy and exercises. This includes stimulation actions to the lip, tongue, jaw, soft palate, pharynx, larynx, and other respiratory muscles. They intend to influence the physiological structures of the oropharyngeal mechanism to improve the function. Like in laryngeal elevation, you again in the same, it's more or less same like Mendelssohn's. You tell the patient to elevate the larynx and swallow food. In Masako on tongue hold, which has been remarkably helpful for me in Parkinson patients who have base of tongue dysfunction, we ask the patient to stick the tongue out, hold it with the teeth or the lips, and then start swallowing their saliva. This is difficult even for a normal human to get to do swallow for more than 3 to 4 times while you do Masako. So this helps. This helps the posterior 1/3 of the tongue to, or the base of the tongue to clear food residues at the level of your vallecula. This because of the tongue weakness of the base of the tongue, the food gets stuck inside in between the tongue and the epiglottis, and the food residues are moved quite nicely. Then we have got shakers exercise, head lifting exercise. For a lot of my lateral medullary syndrome patients, this is called Shakir's exercise. And Prasanna ji will correct me always. This is not shakers. This is Shakir's exercise, the head lifting exercise. This has helped me a lot with my lateral medullary syndrome patients. This exercise, we tell the patient to be in a supine position and then pick the head up. Look at their toe and keep it for 20 seconds or count 20 in the mind. What does it do? It actually, the hyolaryngeal elevation or excursion is maintained properly, and the upper esophageal sphincter is relaxed. That is what is important in case of upper esophageal sphincter spasms. Then we have got lingual isometric tongue exercises or oral exercises where we give external active or passive movement of the structures, and we give a pressure, external pressure, and against which the patient has to move. This always helps to increase the range, the speed, and the strength of the articulators, which were important for your swallowing as well. Then compensatory are postural techniques where we tell the patient to go into different postures which would direct or to change the direction of the bolus, which would go inside your pyriform fossa and into your stomach without having much of a difficulty. It is like somehow you're escaping the route into the trachea. So postural techniques may be appropriate. They appropriate to use with neurological impairments, but most of my head and neck cancer resection patients, I go with compensatory mostly. Even other maneuvers do also help. Now we have got chin down posture. Here we ask the patient to put their chin down, drink water so that the water does not go inside the airway. As I've told before, the airway is blocked, the esophagus is open, the water goes in very well. We have seen this happen when we did fees for a patient. We have asked the patient to do chin down, his laryngeal vestibule closed, his esophagus open. That was good. Chin up posture mostly followed if they have a glossectomy tongue where the tongue propulsion is affected. So you can ask the patient to do a chin up, push the bolus back, or do with the gravitational movement of the bolus goes back, and then you can have a control over it. So this is compensatory. This is not always, this might help for the patient to maintain safety for the swallow. Then we have got head rotation, turn to side. This is mostly to avoid the to give a direction to the bolus to the proper side. And then we have got similar something called as a head tilt, which also is done in the affected side to close off the affected area so that the other pyriform fossa can be opened up and the food can pass through the other part. So there are a lot of controversies with the theory, but head turn and head turn or head tilt to chew the food and to direct the bolus, and head turn to actually block the affected pyriform fossa, and the food passes through the normal side. Okay. And then definitely we have got biofeedback systems. I have got, luckily I've got a, Vital Steam Pro, which gives SMG reading. I show it to my patients, and they kind of understand. It's though it is a bit difficult to include in all the patients in Indian scenario, but we definitely try to do that. And it is also a bit costly. But anyhow, you can give biofeedback from a VFS recording also, or through a fees also. That's not a problem. You do not have to always go for a SMG. Uh, then we have got diet modifications, the different textures of food. This is very important. This is very important for you to educate a caregiver, a sister, a person who is going to stay with the patient, that certain modifications do help the patient. Okay, absolutely help the patient. So even the temporary change in temperature also gives a sensory feedback to the patient. The meal planning. The meal planning is very important. What we do in a hospital, let's go step by step. The consistency of the food, nil. Amount of food, nil. Examples, what we can do, we can ask the patient to manage his own saliva. This happens in a case where you've got, for what I see in most of the ICU settings, as Prasanna sir was telling, I also get referrals for tracheostomy patients. When I do the swallowing, the first thing I see is that he's holding up a chunk of, or he has got a severe pulling of saliva in the back of the mouth. So I ask the patient to do a lot of dry swallow to clear the bolus, to stimulate those parts and clear the bolus. This time no food. And then slowly, as I have confidence, I do a four-finger test. I see the patient is elevating his larynx. Even if I've got an instrument, I can go into the nasal cavity and see if he's able to clear the pulling. Then we can go for thick liquid, let's say 2.5 ml per spoon, which can be soup or vegetable stew. And then slowly we increase the consistency. But for me, in neurological patient, the last option would always be thin liquids, because water is tricky for neurological patients who have got poor neuromuscular coordinations. Water can slip off very easily inside the trachea. So for semi-solid, I mostly go with semi-solid, and I end up having liquids and soft diet. I leave the patient on soft diet, and slowly solids can be given after they have chunk of therapy. We have got electrical stimulations also. We may mostly use the Vital Steams Pro, and then we have got other equipments which can bypass the the larynx, the different modifications which we can make with the utensils. We have got pacing and feeding strategies also. This is done for mostly the cognitive impaired patients. We can change the bolus size. We can tap and tell the patient to have the food along with the rhythm, so that they do not go with oral stasis. They do not hold the food in the mouth. We have seen a lot of patients holding the food and sitting like this. We can actually do certain rhythm or tapping for the patient so that they follow that. Then we have got prosthesis appliances. These are again appliances which we can have, like appliances like palatal lift processes, where food regurgitation to the nares can be avoided. We have got palatal plates which has got some sensory vibrations which can always help the patient to swallow better. This is mostly done in head and neck cancer patients. Sensory stimulations are very important. We can use either very simple. You've got a laryngeal mirror. You can change the temperature and you can stimulate the different parts of the mouth. So, and you also have got glycerin swabs. You can just take make it of your own, make a lemon syrup, and you can put it inside the small bit inside the patient's mouth, and he will start at least moving his mouth and trying to initiate swallow. Okay, going very fast. There are two types of normal feeding: internal feeding and enteral feeding. So in this first part, we have got this intravenous drips which are given to the patient. For internal feeding, we have got the Ryle's tube, the PEG tube, and the patch tube. You can see in this picture, this is quite explained. So a PEG tube is a percutaneous endoscopic gastrostomy tube. This is inserted through the abdomen to provide non-oral nutrition. The geostomy tube or the patch tube is inside the second part of the small intestine, which is called the jejunum, and the nasogastric tube or the NG tube or the tube which is inserted from your nares into your stomach This is mostly common. And we have also got freca. Freca tubes are given to avoid injury to your laryngeal cavity. These are again smaller tubes. Okay, now the two more slides. Chananda, he is already knocking me, so I'll finish it off very fast. Treatment consideration related to progressive disorders and end of life issues. We always encounter this kind of patients. SLPs may encounter patients approaching to the end of life. SLPs have to work like a team with these patients and with the caregivers to develop compensatory strategies. As a member of interdisciplinary team, SLP should be able to give decisions that this is the kind of thing he is in, he needs this, he needs this. And we also have to look into the psychological and emotional issues related to death. When coming to the end of life issues, it is also important to respect the patient's wishes and including the social and cultural consideration. Now, the last, which is my conclusion, I'm going to discuss 1 minute about a patient whom I have seen. Now, one of my first patients, when I started dealing with dysphagia, he was a 77-year young man diagnosed with PSP, a PT variant. When I saw him, I could not recognize him. Later, when I came to know that he was one of the most famous RJs, radio jockeys in the early 90s. I was told to feed him and help him speak. He was not an easy patient because he has lived his life with glory and fame. I used to motivate him to speak louder and make him listen to his own old recordings. We used different strategies for him to swallow without cough. It was his wish that he wanted to live and die with dignity and hence request not to go for a non-oral feeding tube. I could only serve him for 2 years and at last he left us being diagnosed of aspiration pneumonia. I was unhappy then, but now when I think of him, I always remember the everlasting smile on his face till his last breath. So it's always difficult for our SLP to actually counsel the party, but you should be able to understand or receive it according to the circumstances which are coming into your way. Depends on the patient as well. So this is the end of my presentation. Thank you everyone for listening to me patiently. And am I
Thank you
visible?
so much. Yes, yes. Yeah, thank you so much for such an elaborative presentation and about your case presentation. Ultimately, we all are humans and we have to, take care of human emotions also in consideration. There are a lot of questions for both of you. I will start with first for Mr. Prasanna. How much should SLP charge for a swallowing therapy session?
Yeah, that's a very difficult question to answer, and yet it is very important question. You have to analyze a lot of things there, which area you are there, and what is the consultation charges are like. Now, best guide for you would be if you are in a hospital setup, what is other consultants charge, and if you are in a tier 1 city, the trends are somewhere between 1000 to 1200. 800 to 1200 per session. There are people who are taking 2500, 3000 as well. And there are people who are doing free for service as well, as in no fee for service, but free for service, right? So free of cost service. So there are people taking 400 rupees session. Now you have to calculate your finances. Now, if you can meet your expenses with what you charge, I think you should be able to go ahead and give uh, whatever rates you want. But it is always better to fall back on the association and say that what is the trend which everybody is following. Now
Yeah.
you go to an association and you force the association to make that kind of guidelines, right? That is the first step you should take to empower an association to help you back, right? So it is not an arbitrary number that you charge. I mean, it depends. If you see somebody is parking a BMW car outside, probably you can charge 1500, but still they will ask why 1500, right? So you should be able to justify. You cannot justify this that you have a BMW outside your house, that's why I'm charging you 1500. So if your service costs so much, you should only charge that much, and on top of that you can give discounts. So that's up to you.
Okay, thank you. The next question is, please share the source where I can refer to the rules to be followed during teletherapy for people having swallowing problems?
Yeah, I think I can mail you all those things. There are very beautiful guidelines, laid down by some of the universities. We can do that. There are,
Okay.
I think DRS guidelines are there. There is European Swallow Society guidelines are there. Society for Swallow Disorders guidelines. I think I can share it with the team.
Yeah, so we can, with the ISHA permission, we can have it on ISHA website also if it is allowed. Yeah.
Garima
Okay.
ma'am, I want to add up with Prasanna what Prasanna ji said. Before the last question, how much to charge? I would
Yeah.
also say that it depends on the kind of place or town or city where you're in.
True.
May depend.
That's
You should always consider the economical condition of the patient as well.
true. Yeah. Thank you for the
Do
input.
you all
Next.
do
Yeah.
you all charge
Please.
per session or monthly?
No, it's good.
For
Like
example, like for a speech therapy, we have like a particular amount for thrice a week or something like that.
you can pay weekly or you can pay daily. It's like
I think it depends on which setup you're in. Now, if you look at a hospital setup, it is a consultation basis. Now, patient comes to you, you see the patient, review, advise, and they go back home. There is
Yeah.
nothing in between. So we are trying to change that model into, making the patient come back to a therapy unit. So hospital consultation business should have a backup therapy unit as well, where regularly therapy goes on. No, it depends on the package, depends on the severity, depends on logistic reasons, and upfront we are proposing for a tele-rehabilitation, right?
Okay.
So in head and neck cancer, we are asking for tele-rehabilitation. If the person cannot travel to hospital, not necessarily everybody is staying around the hospital area. So we make sure that we do a rehabilitation service as well, not just consultation.
Yeah.
So for that, it depends on a lot of factors. Their paying ability also matters. But if we think that by treating, they are going to have better quality of life, we are going to make adjustments on those charges. For us, we have one payment per week, but we may take 5 sessions per week or 2 sessions per week based on what is the need of the patient. So there will be only one payment per week.
Yeah. Okay. Thank you. Next question is to Mr. Bhaskar. The statistics which you have showed, is it based on patients that come to your hospital alone or in India or as a whole?
no. It's an international classification which I've given. It's not. I did not do any research, extensive research on. Yeah, but we were doing on stroke prevalence, like dysphagia prevalence in stroke. The study is still going on. We are trying to put it in seeds. There is a data collection what is happening, but that's for stroke alone. This is one of the references which I got. I can give you the reference of the article from where I've got it. I can share you with it.
Okay.
I used it
There's
for my
one.
presentation
Okay.
from. Yeah.
There's one more question to you only. How can we rehabilitate a aphasia patient for oral phase dysphagia?
For a oral phase dysphagia, you first if the patient for oral phase dysphagia, like if the patient is showing aspiration or holding the food in the mouth, what is the exact complaint? We have to go for that. But if you have see what kind of aphasia is also important. If the patient is having a Broca's aphasia, he can always be told. His comprehension will be fine enough that he can be told about the different things. You can go for oromotor exercises. Definitely, there is no problem in doing oromotor exercises. It will improve the apraxia, aphasia, a part of aphasia also, and it will also improve swallowing. So if you ask me for a left MCA patient getting admitted to my hospital with a Riles tube, which was put in the emergency or the ER, we are definitely confident that if we remove the Riles tube, if we give therapy, if we can make the patient eat a bit early, then the patient's language might come back a bit faster. The patient can be taken out of emotional steps, and the patient can also reduce the amount of apraxia which is present there along with aphasia for the patient. You can do it. For warning aphasia patient, I think mostly if you go for simple oral trials, they do not have that much of problem if the extent of the bleed is not so much. Yeah,
Okay.
for a global aphasia, you definitely go for a Riles tuber. You do not, if they have a head injury so large, or they have a hemorrhage so large, it has crossed the midline, the other hemisphere is also affected, there is a raised ICP for the patient, you do not go for oral feeding. You can only go for passive therapies for the patient.
Yeah, wise enough. Yes.
Stimulations, yeah.
Yeah. So next question is for Prasanna. Can we set up a dysphagia clinic with equipments only, with minimal support from allied professionals? How much safe is it from legal point of view?
I think Bhaskar is the best person to answer that question. I even wanted him to take up my topic. Legally, there are no strict policies laid out in India. Now, if you look at US or European, this one, they have specific things about, how much should be the professional working, how much should be the space required, what are the requirements. You should have a emergency room, you should have a skilled nurse, who should be taking care of it, and there should be licensing for doing certain procedures and other things. So competence is something which US and European community looks at, but India, it's not that much. Like I said, I mean, we're not far too behind from getting into these legal aspects. I think we should keep going back to the association. Like, I always say, go back to the association. Let the bigger party do the homework for you, right? Because if you are going to get helped, then a lot of others are going to get helped. Let them lay down the guidelines. Let them at least facilitate those things to be done. Now, you can follow infection controls and other things like how anybody else would do it. And also, I would suggest that don't do it independently just because you can do it. It is always better to have a medical professional, especially ENT. Make sure that that person buys into your vision and mission for the clinic, and then, they're not too dangerous for them to have with you for practice.
Yeah.
Okay.
Otherwise, legally, any service is important for us, and we should be doing the right thing in what protocol we have set and what has been given as guideline from the organizations.
So
Any
right
service,
now
not
you,
just swallowing.
yeah, yeah. So right now you both are practicing at different places. So do you follow a common protocol, or protocols are different at each of your workplace?
Bhaskar,
Yeah, so see, like the basic swallow protocols, the assessment protocols are same, but definitely the type of population of patient what he faces is mostly head and neck cancer, and what I face is mostly neurological or ICU patients, post-intubated patients, like or tracheostomy patients related to those. So yes, for that the assessment or the management protocols may vary, but basic protocols are always the same. About the legality thing, what you were saying earlier, I would only say one thing, that whenever you go to and apply for clinical setup certificate, the clinical competence certificate, this, when you go to a corporation and you try to apply for your clinic, they would always ask for a medical professional whenever you're doing a clinical setup for this kind of endoscopic thing. So you definitely would like to have a doctor around you. You can always tell a group name of group of doctors or a single doctor associated with your clinic, and that's very important again, that it's very useful if you get a ENT doctor or around you when you're doing the test. In case of any medical emergency, it will be always handy.
Okay, that's nice. So we can have a, set protocols and display on ISHA website. If you can help us in future for that, we'll really would like to have it from ISHA. Next question is, how much safe is the swallowing in a sleeping position for a patient with mid-segmental mandibulectomy reconstructed with a PMMC flap? What can we do as a SLP to rehabilitate this case?
Bhaskar, I will take that question.
You don't
The
understand like alien languages. You
sleeping
please.
position, is it two different question or is it the same one?
It's the same question.
Same question. So, there are some school of thoughts, they say that sleeping position is the safest position to swallow. But I would add to that sentence here that it is not an efficient position to swallow. So it may be safe. It may not go into the airway, but it does not clear the pharynx, is what I believe in. And of course, now gravity it tends to stay towards the back of the throat, or lower, that is near the pharyngeal wall. But that is not the normal physiology, like how Bhaskar said about mid-segmental mandibulectomy. There are very rare cases on mid-segmental mandibulectomies. Not many have done it. In our hospital also, if there is a wide local excision and lip is involved and anterior uh, mandible is involved, they would do it. Swallowing, I am not really worried, because it's more anterior deficit or anterior treatment. We should be able to go to soft at the earliest with clearance from plastic surgery, provided no other comorbidities or no other complications occur, because it is going to be a morbid plastic or reconstruction surgery. The flap has to settle, so it will be uh, you know uh, very sensitive flap at that area to give away or become failed. So those things considered, I think rehabilitation is not that of a challenge. But when it comes to aesthetics, patient keeps asking you about whether I look good or not. So I don't think speech and swallowing will be the primary concerns for them.
Okay. Okay. So next question is, what about the treatment instruments like EMST, vital stem? Your view on its relevance and also about its certification.
Yeah, like, we have Vital Stim Pro in our hospital, but to be very frank with you, you don't go alone with these instruments to treat a patient. It's like a all-around treatment, in which, in certain ways, the instrument may help you. It actually, what it does is it contracts the suprahyoid laryngeal muscles, which helps in laryngeal excursion, the movement of the larynx upward. So it gives also, you can also show the patient how much the larynx is elevating. Getting a certification into it is good. Other than my hospital, I know there are very few places where these instruments are implemented. They are also used by physiotherapists. If these instruments, like the doctor who came for a vital stim demonstration in our hospital, was a physiotherapist of his own. Like he was a physiotherapist, and they do it. They have a neuromuscular electrical stimulation theory behind it, NMES. They also use those for paralyzed arms and legs, and they are effective. But along with your therapy, definitely, along with diet modification, definitely, you do not feed a patient biryani after giving therapy with vital steam. So it's like you have to go along with all the other strategies.
Yes.
Certification.
Okay.
So
Yeah.
if I
So
may add,
yeah.
just a quick addition. Now, most often, because patient demands for vital stim, we use it, because they would have undergone the treatment in US and they've come back here without looking at why or how we need to be using. Of course, the skills and competence is important, but also how much is it helpful is something which is needs to be studied well. Yeah, vital stim, if it is neurological cases, yes, it gives better opportunity for outcomes when compared to head and neck oncology patients. But EMST, for that matter, both ways pulmonary will be compromised. If pulmonary system can be strengthened using EMST, then it will be easier. So EMST can be given as a standard protocol for all the patients who are having, at risk for aspiration pneumonia or swallowing difficulties. So strengthening pulmonary aspirations will reduce, pulmonary functions would improve outcomes, also reduce the chances of readmission to the hospital because of feeding problems.
Okay. Okay. That was a useful information. Okay. So is this is to Mr. Bhaskar. Is there any protocol for deciding the amount of food, like when to provide 2.5 ml and when to begin with 5 ml?
See, it always like we in hospitals do not have time to find protocols for all chunk of patients, but definitely there are guidelines where we have learned, but it also depends on how much the patient is able to have in a bite. You have to assess. You have no time to assess standing around the bed. If you give half, if you give a full spoon, if you see the patient is aspirating on the food, you can always give. If you consider a spoon to be of 5 ml, you give half teaspoon. That's it, 2.5 to be on the safer side. And then again, slowly, when you gain confidence over the patient the patient is able to take that much amount of food or
Then you
bolus,
can.
size bolus, then you can slowly increase it down to 5 ml or even 10 ml.
Okay. Yeah. Next question is
Can
to
I add?
Prasanna, sir. Yeah,
Yeah, yeah.
please.
Please ask the question. I think I'll add
Ah,
answer both the questions, sir.
okay. Is BSLP enough to start a swallow clinic?
Oh, that's a very, very good question. So I think I'll ask, add a point to Bhaskar's question about, I mean, your question to Bhaskar about amount. If you're an educational institute or if you're a research institute, you should follow strict protocols. And if you are training students and there are people watching you and what to do and how to do it, I think you should do a standard protocol. But if you're alone, you don't have that much leverage on time or luxury because your OPD is running full and you have to finish off things faster and you have very brief documentation, how much ever is necessary for legal aspects or documentation purposes. So with that, we'll be able to do it. But if you can do it, good enough. Otherwise, no need to, too much spend too much energy on those things. And the
I would
second,
ask sir, one small question, person.
yeah,
Have you ever had a problem following the protocols with the dysphagia patients?
yes, with the time.
With the
So
time, okay. Has it
yeah,
anyway?
not just the time. Most
Yeah,
often, we
yeah,
would stop the study because the aspiration we would already answered our clinical question,
yeah,
right? So now, if my question is to see whether the patient can have liquids or not, I would just have liquids as less as possible. Even sips of water is fine. If the patient is having aspiration on 5 ml, I go down. Of course,
yeah.
now if 5 ml is aspiration, 10 ml definitely there will be aspiration. Reduce the quantity and see if it is working for you. And it also depends on your clinical question. But following the protocol is very good if you can do it, if the time permits, and at least you should be able to have basic protocols,
Yeah,
standard
that's true.
protocols for it.
You don't
And
start with
this
BSLP is
BSL,
enough.
uh, I'm not sure if Premlata ma'am is here. As I want to see if Premlata ma'am is here. I see competence. Competence is very important. We are treading in a very dangerous water when it comes to aspiration, pneumonia, and swallowing. A physician or a doctor will not miss a chance to diagnose any pneumonia, any infection of pulmonary system as aspiration pneumonia. A smell of cough or smell of problem in swallowing can lead to diagnosis of aspiration pneumonia. So these are the things which requires little more than just an education. I would say even master's degree is not enough, right? You need to have that skill developed within you. You have to have supervised cases to be taken in during the your educational programs. And I have seen bachelors picking up skills better than masters, right? So I reserve my answer to that question. I would say competence is
Mostly the
something
skill.
which is very
Yeah.
important. And I would also always want a patient or patient caretaker to be a swallowing specialist for that instance. So I think it is a trainable skill, not just about knowledge, but trainable skill. But if you want to make decisions, have proper breakdown strategy management and all, you need to have that theoretical knowledge as well and connect with theory as well as practice.
Yeah,
yeah.
that's true. Yeah. So next question is, I would like to know what are the ways to monitor aspiration except SpO2 monitoring or cough?
Okay. Like
Yeah, I think
You want
SpO2
no,
SpO2 is not a I mean, if somebody is said that except for SpO2, that means SpO2 is standard protocol. No, SpO2 I
no,
think is the least one. it does not tell anything unless the patient is already having a desaturation earlier, right? The best way to look at is, yes, cough during the swallowing, before swallowing, and after swallowing. It depends on how you analyze those things. And then if you can look at voice quality post swallow, before even giving anything, you can screen the patients for risk of swallow, and then you can decide whether you want to give anything orally or not. And if there are silent aspiration, there will be very minute changes, like patient would be always doing throat clearing, secretion, saliva would be trickling down and other things. And then if it is prolonged duration, so there will be temperature change, or low grade fever is something which you need to look at. There are other signs also, like if you're doing a cervical auscultation using a stethoscope, you will be able to do it. So you put objectivity in your subjective test, and those things becomes better recognizer of aspiration pneumonia, aspiration or penetration for that matter.
Okay. So next
Bhaskar, I
question
think.
is patient. Yeah.
Yeah,
Patient
it's
with
same. So you might find sometimes a bit of tachycardia also in this kind of patients who might have silent aspirations or known aspirations other than cough. Might assess the voice quality of this patient. Definitely. Thirdly, that you have to do beforehand. You have to understand the sensitivity of the larynx before giving food. If you give food and the patient aspirates, then your decision is wrong.
Yeah, that's true. So the patient with absent gag reflex and a post-stroke patient, what would be the swallowing outcome?
In a post, I would answer this. Like if you consider gag is important, there are a lot of studies. There are a lot of studies which say the gags are not important. If gag was important, how would a snake be able to swallow? Snakes do not have gags, but they're on keeping it out of the mind. Yes, we definitely test gag. Like having a gag reflex is definitely a good indicator that the patient might not aspirate. It is a protective function. It has nothing to do with swallowing. It is against unchewed or a bigger bolus or something foreign, which is trying to go inside the esophagus and it's trying to take it out. It is something of antiperistalsis which happens and the food comes out. So it's nothing more of swallowing reflex, but yes, a good gag might indicate as a clinician, if you feel about looking at the SpO2 and the heart rate of the patient, the sodium and the potassium of the patient, the TC and DC of the patient, you can always look and check if the gag is present or not. That's
Okay.
an indication.
Okay.
But absence does not mean that the patient is not going to swallow. No.
Yeah, true.
Anything to
Okay.
add?
Yeah. So next question is how to initiate swallowing therapy, particularly if the individual having cognitive decline.
Okay. If I tell
I
my, oh, please, Dada, I would tell later. No problem.
I think cognitive deficits usually should not be considered as a direct cause for swallowing problem, because it is beyond the swallowing problem. I mean, swallowing is generally considered as a reflex action. Like if you maintain everything else, like posture, the time, the control of the bolus from outside, you will be able to do a good swallow with even a GCS 8 or 7, even lower than that, in patients like TBI, where the patients are not cooperative, right? But if other things are not there, for example, if the patient is on cuffed tracheostomy tube, the patient is not able to handle swallowing of saliva, then you know that the patient is not a candidate for doing anything. So you would look at just non-food trials and indirect swallow therapy, facilitation of normal functions, just using dry swallows and other things.
Yes,
So I think
absolutely.
cognitive deficits will only increase the swallowing problem if there was swallowing problem.
Yeah,
But
yeah,
having cognitive deficits does not indicate that there will be a swallowing problem.
Okay. Okay. So next
so
question, if patient has, yeah.
a therapy for a cognitive decline for a patient having cognitive impairment is to work on more efficacy because safety, if the other things are already there, safety is already maintained. You work on the efficacy so that they can clear the bolus or not pocket out through the mouth, having it in a better way. Yes.
Okay. The patient has lung infection post swallowing cough and has to be fed through NG tube. How safe is it? What are the precautions to be taken? I think you've already answered a similar question.
No, but
Yeah.
she, he or she who has asked the question has already answered for it. If he has a lung infection, is post-dilutive cough, he's already on NG. That's good.
Yeah.
But
Yeah.
that is the first step of your treatment. And if you want to cure him, then you have to understand why he or she is having aspiration. You have
Okay.
to do a proper assessment for that, and
Okay.
then you can.
When Yeah. Okay. Thank you. So next question is, I'm sorry, I'm rushing. uh, when working with a private practice or taking up home visit, which medical expert's letter is important for clearance to begin swallow therapy?
I know no one's. If you
I think,
ask me, no, you are efficient enough.
see, patient consent is important. If the patient wants, you need to go, provided you know everything about the patient. I think it is best to connect with the primary consultant. Let's say if the patient is from a neurological hospital, you call the patient's neurological consultant and make sure that the doctor knows about all, what you're going to do. Also take input from them on what they were doing. Usually you might get some negative response. That's okay, because anyways you're going to go forward because the patient has given consent, right? But you need more than your clinical evaluations. You need your what are the medical condition, what are the comorbid conditions, because these doctors read the charts and know the patient much more than what you can read. So I think you should fall back to them for any kind of clues on whether it is a dangerous case or is it safe to go home and do it.
But I want to raise a dispute against this. I just want to say, if a patient comes to clinic and says that he has got a swallowing disorder, then you can be the first person to look around the problem and recommend him to go for a person from whom we can get relieved, either a gastroenterologist or a neurologist or an ENT, if you find the rest of the problem. And if you have the patient's consent, definitely what Dada was saying, you can start off with the therapy and also relate to the consultant. That's definitely there. For a hospital setup, it is very important to have a medical backup behind you. But
Yeah,
yes, you are
Fair
that's
enough.
why
eligible
I
enough.
said That's why I said Bhaskar was supposed to take the setting up clinic. He's become more famous so that people come to him with swallowing problem. I think other places usually don't get complaints of swallowing problem directly. It's always referral business for us.
I would.
Congrats.
Congratulations on that.
Yeah. So our next question is, can we make use of double lumen tracheostomy as a protocol in case of head and neck cancer? How much is single lumen tube helpful for surgical and radiation patients?
So I can guess the person who would have asked these questions, but still I'm going to answer. Uh, so head and neck, I think if you have a protocol on double lumen and which is a fenestrated tube, it is going to give you a lot of freedom to work. Okay, the one thing is that, like I said, you need to get an opportunity to work with these patients, make sure they talk early, make sure they start oral sips early, get clearance from the plastic surgeons, make sure their breathing is okay, even in emergency as well as elective tracheostomy procedures, right? So if you're able to clearly say that whether the patient is able to voice with tracheostomy or not, if the patient is able to swallow safely or not, your decannulation process becomes faster. Once the decannulation is faster, your outcomes becomes better and better, right? So you cannot go blind if there is a swallowing problem. Having a tracheostomy tube is the safest way to give anything, because you will know if something comes through the tracheostomy tube or not. In these cases, you will know, won't need instrumental evaluation in most cases, right? Of course, to understand the physiology, you would want to do an instrumental evaluation, but I think it should be a protocol where you should be able to initiate speaking as well as swallowing with the tracheostomy tube. The problem with other single lumen tube is the space between the tracheostomy tube and trachea is so less that you have to really force the patient to voice, which is not good. So there are other schools of thought where you use a speaking valve, swallow becomes better. Negative subglottic pressure can be achieved. With all those things, you'll be able to achieve much faster than just a single lumen tube.
Okay.
I
We have a
just
question from an sorry.
So just to add one small thing, I want to say that for a single tube, we mostly find that the tube gets blocked very easily with the hard sputum. For a double lumen tube, it is more easier to remove the inside lumen, wash it with the normal saline, and re-put it. So, care of the tracheostomy tube is better. So, if you keep it in a protocol, it is okay. But if you're trying to remove the tube as early as you can, you might use a single lumen also. Yeah.
Okay. Thank you. We
So we
have a
have
question from
last
an
question.
ENT surgeon. Yeah, that's the last question. That they have started a dysphagia clinic, but they are facing problems with dietary modifications, and they are unable to get all consistencies. They would like to know about how thicker you suggest.
No, actually, I also read the question. Uh, Doctor is from JSS Hospital, Mysore. So if any of our SLP colleagues and attendees, please contact them.
I would add to that and say, go to a dietitian in the hospital and ask subtly whether they are following ISSI diet modification, the Dysphagia diet or not. If not, make sure they're aware about all those things. And dietitians or clinical nutritionists will be able to provide alternates for thickeners or different kinds of consistencies. So that is their area of expertise. We can only say that, okay, this thick is safe for the patient, but the ones who would give the recipe for it with nutritional values, somebody who's with a clinical nutrition knowledge.
The last question, where 2-3 people have asked about the certification and training about fellowships for swallowing.
There are two one-year fellowship going on currently. One is happening in Tata Memorial Hospital, which is a prestigious one, which has started first in the country. That is 1-year fellowship. And then one is happening in HCG. That is again 1-year fellowship in oncodeglutology, same like how the Tata, that is Arun Balaji is doing. And there is another fellowship which is of 4 months with Dr. S.R. Chandrasekhar Institute of Speech and Hearing is doing. I'm not sure if currently they have resumed the work or not. Because of COVID, there was a halt. But you can also look at MSc program, which is going on in Amrita University, deemed university in Kochi.
Dr.
You
J. Kumar
know,
Menon.
yeah. So but a word of caution, if you are looking at certification and recognized by a recognizing body, the MSc is not yet recognized. Even the fellowship also, Tata Memorial Hospital by name itself is a famous one. It is recognized by the institute itself, and even HCG is in-house fellowship where university affiliation is being processed. So I think there are two 1-year programs, one 4 months program, and another one is 2-year swallowing program. And we also have online fellowship, which is for 6 months, where we have mandatory 15 days, a minimum of 15 days hands-on, where they take up online modules to have self-learning and classes, one-on-one classes. So that will be more focused towards oncodeglutology.
Thank you so
And I
much
also
for
want
yeah, please go ahead.
I'm also motivating others to take up these fellowship programs, contact programs where centralized courses can be run and a person can have a local training. For example, if somebody is there in Kolkata, Bhaskar, they can become the resource person. So just the syllabus needs to be followed in Kolkata under Bhaskar's guidance.
That's actually a very good idea. And with ISHA also we can take this up if it is possible. We'll definitely come back to you to discuss this in detail. And I would like to request Chandan sir to give word of thanks.
Thank you. Thank you so much, Bhaskar sir and Prasanna sir, for accepting this presentation. It was really excellent. Now our objective was only to let's see how many SLP can start this practice, and you both are always there to help. And thank you, ISHA.
Absolutely.
Thank you, ISHA SIG group. Thank you all the attendees for attending this program. Happy Following Day.
Absolutely.
Thank you.
Happy
Thank
World
you.
Following Day.
Happy
Yeah.
advance to everyone.
Namaskar.
Yeah.
Thank you so much. We'll close for the day. Thank you once
Yeah.
again.
Thank you. See
Thank
you.
you,
Good
guys.
night.
Good night.
Nazar, thank you. Bye. Good night.
Good night.